I will not try and cover the whole gamut of genitourinary tuberculosis. I will just take you through a few interesting cases. And Bhaskar, if I exceed 15 minutes, you can just stop me. So the first lady is a 60-year-old female who presented with systemic symptoms. The predominant symptom was continuous urinary incontinence. Also accompanied by some urgency and frequency, she was changing up to 5 pads a day. Clinical examination revealed an obvious vesicovaginal fistula. There was bilateral hydroureteronephrosis with an empty bladder on the ultrasound. The acid-fast bacilli and MGIT cultures were negative, but TB polymerase chain reaction was positive. Now, this was her VCUG with bilateral vesicoureteric reflux and a small capacity bladder. I know this picture is difficult to read, but you'll have to take my word that there is a fistulous communication in the bladder and the vagina. This was better demonstrated on the CT scan, which also showed a very, very small capacity bladder with contrast leaking into the vagina. Cystoscopy confirmed the fistula. Now, what we did was a cystectomy, a hysterectomy, and the vault closure was done with anomental covering. The bladder was too small. This is something I would like to emphasize here, that not all bladders can be augmented. The bladder was small, and we decided to do an ileal conduit for the urine drainage. The histopathology, of course, was consistent with tuberculosis. So this is the actual picture of the case. Not very important to describe things here, except that a VVF is not treated any different just because it is tubercular, but the bladder capacity and the vaginal capacity need to be managed. An interesting question that I had was, where does TB begin in a fistula? Does it begin in the bladder? No. If it is in the bladder, there will not be a fistula formation. It is usually vaginal tuberculosis which ulcerates and then leads to a VVF. In the repair, like I said, the difference is not much, but an additional augmentation, or if you're comfortable, even a neobladder is accepted. But remember, this is not just for tuberculosis. This is something we forget in VVFs, that these women may need a vaginoplasty to have normal sexual intercourse. Tuberculosis does have a bad effect on female infertility because it affects the tubes. Now, going on to my next case, this was a 26-year-old unmarried lady with left flank pain for a period of 6 months. She had no systemic symptoms. Again, another point I would like to emphasize is that in genitourinary tuberculosis, these patients are unlikely to present with systemic symptoms unless they have an additional complication like renal failure or an active bacterial infection. Ultrasonography reported left moderate hydroureteronephrosis. Again, all we had was sterile pyuria, and she had, when she presented, her creatinine was 2. So this was the left bulb ureterogram that we did. In order to allow the creatinine to normalize, we left in a percutaneous nephrostomy and started her on anti-tubercular treatment. The question was, what do you do for this kind of a stricture right up in the ureter? We did not want to do an ileal conduit. So after 2 months of ATT, again, this is a point that needs to be emphasized, that on anti-tubercular treatment, the extent of fibrosis that you see can progress. So do not depend on any imaging that has been done 2 months ago. Re-evaluate it. And when we did that, we found that actually there was not much of a change as compared to the previous findings. What we did was we placed a buccal mucosal graft onto the retroperitoneum and did a ureterotomy. Now what you see, I can't show my mouse here, I'm sorry, but The whitish part is the graft, and the reddish thing is the ureter, which has been opened up. And these grafts do take up on the retroperitoneum itself. So at 7 weeks, she is asymptomatic, and this is the status of her drainage. We have a 1-year follow-up on this lady, and she's doing quite well. Now, what are the alternatives? So BMG ureteroplasty is a good alternative for the upper ureter. The evidence is, of course, very short series, maybe 5 or 6 cases, because it is a relatively new option, and a lot of people don't believe in it, but we did get clinical outcomes here. So the fatty tissue over the psoas, and if you want, you can get additional vascularity if you bring in omentum or close to this. What about a lower ureteric stricture? Can you do a BMG ureteroplasty? The answer is an absolute no. The lower ureter has poor blood supply, and you do need to implant it. If an additional small capacity bladder is there, you will need to augment that too. So that is about a ureteric stricture that we salvaged. Now, this lady came with systemic symptoms and with storage lower urinary tract symptoms. She used to pass around 50 ml each time. Clinical examination was normal. Ultrasonography showed a right small kidney, a very small capacity bladder, and the right kidney was not really working on the DTP arenogram. She had a positive AFB smear and positive culture. And this is what her bladder looked like. Small capacity bladder, trabeculated, and bilateral reflux. The reflux, of course, is secondary to the bladder. We don't need to worry about that. But what do we do with this bladder? This seems to suggest that the capacity is about, like we said, only about 50 ml. A very, very small bladder, we would not attempt an augmentation, but this is the kind of bladder you may attempt an augmentation. So the first thing to do would be to do a cystoscopy and assess the bladder capacity under anesthesia, and then decide on what you want to do. Other than augmentation cystoplasty, you have an ileal conduit. When to decide on augmentation? Of course, you would need good renal function. This lady's serum creatinine was on the borderline at 1. The choice of bowel segment, what we do is the ileocecal segment without detubularizing the cecum. What we feel, there is again no evidence to this, is that the detubularized segment allows them to void better. An orthotopic neobladder, again, there is no contraindication. The sphincter area is absolutely normal, and you could do an orthotopic neobladder in these patients. Coming to a gentleman who presented with a right scrotal swelling of 2 months duration. It increased, slowly increasing in size with erythema, no systemic symptoms at all. I'll go on to the picture. This is what it looked like. There is this not really tender swelling, and it does appear hypoechoic on the ultrasound. The ultrasonography reported that the testis was normal, and this was essentially an epididymal swelling. We excised the epididymis and sent it for biopsy. Remember, without starting ATT empirically here, and the biopsy confirmed that this was acid bacilli were present, granulomatous inflammation was present. So the questions with epididymal tuberculosis is, does it always need surgical excision? So because of the extensive fibrosis, these multiple small tubules in the epididymis, antitubercular therapy alone is unlikely to be effective. The second question was, you do need to excise the epididymis if it is involved like this. The second question was, does the contralateral testis and the contralateral epididymis, does it get involved? It is very unusual, and therefore it does not affect fertility. Do you need to evaluate other genitourinary organs? Yes. While we know that the epididymis is primarily a hematogenous infection, there is no reason to suspect, not to suspect that the kidneys will be safe. Now, you may not always be able to salvage every patient of tuberculosis that comes to you. Again, while renal tuberculosis is usually unilateral, strictures can be bilateral, especially if the bladder is involved. You can have both kidneys involved. Now, this gentleman came to us 6 months after he was put on anti-tubercular therapy with stents. Stents had been exchanged every 3 months, but the creatinine continued to rise. So we placed bilateral percutaneous nephrostomies and the renal function stabilized, but the creatinine was 2.5. Now, this is his picture. I would like you to look at the images on your right. These are very typical findings of tuberculosis. The pelvis is small. It is not a global hydronephrosis. The infundibulae are long and narrow. And when you put in contrast into one part of the PCS, if you look at the upper calyceal area above the tube, not really being opacified. The ureteric stricture, of course, is again a very typical finding. So this patient demonstrated all the typical features of tuberculosis. On the left, on the opposite side, again, this is on the right, that infundibular stenosis, small pelvis, and an upper ureteric stricture. Now, this gentleman's creatinine is 2.5. What are the surgical options that you can think of? An ileal ureter would be out of the question. He would die of metabolic acidosis. There are actually very few options that we have. Either you put him on very short ileal conduits on both sides separately, which again carries a risk of acidosis. What we have left him is on bilateral percutaneous nephrostomies. Another patient with a creatinine of 2.5 was, this patient, we did not do anything. We tried exploring, and then because everything was plastered, we left him on bilateral percutaneous nephrostomies. So long segment strictures with normal renal function, you could think of ileal ureters. If the GFR is less than 30, I really wouldn't recommend an intestinal segment at all. But if you had to do it, a short ileal conduit is what would probably work. And even that has to be done with a lot of trepidation for possible metabolic complications. Now, the last
Manish,
case...
We'll do this as a last case. Yeah.
Yes, this is the last case here. So a 28-year-old male, I'm presenting this because this is an unusual symptoms. He had normal flow with storage symptoms, not responding to antimuscarinics. His fluid intake, please note that he was drinking 5 to 6 liters of water every day and had large volume, large frequency voids. He had sterile pyuria, AFP was negative. He had progressive deterioration in renal function. And when we tried to restrict his fluid, his creatinine would jump up. Ultrasonography reported bilateral mild hydronephrosis, and this decreased after voiding. Gene expert was negative. Cystoscopy revealed a capacity of 600 ml, and cold cup biopsies from the bladder suggested tuberculosis. This is what his bladder looked like. Now, this is a condition which is unusual but not unknown. The nephrologists would probably say it more commonly. It is called tubercular interstitial nephritis. It presents with concentrating abnormalities, and the bladder is just a bystander here. It's become a large capacity bladder. All we were able to do for this patient was leave him on suprapubic drainage. And he has not consented for an ileal conduit. That would probably be another option in here. That is where I will end. Thank you.